Hi, this is Dr. Mario Del Cid at the Retina Group of Florida, and this video is intended to describe some common retinal conditions that we will see in the office. We won't discuss diabetic retinopathy or macular degeneration. This is a separate video, but we will dive into conditions such as cystoid macular edema, central serous retinopathy, macular holes or macular puckers, vein and artery occlusions, PVDs, tears, detachments, and finally endophthalmitis. So let's first talk about cystoid macular edema, or CME. This is swelling within the layers of the retina. The specific layer of the retina involved is the outer plexiform layer. There's multiple etiologies for macular edema. These can include a pseudophakic, meaning following cataract surgery, uveitic, due to inflammation in the eye, due to traction from a epiretinal membrane, associated with leaky vessels, with wet AMD, diabetes, or vascular occlusions, and there's other causes, but these are typically the most common reasons we see CME. A diagnostic test for CME would be a fluorescein angiogram, and the more common description is that of petalloid leakage, usually in the late frames, especially with pseudophakic CME, that is CME followed by cataract surgery. The reason it's called petalloid, you see these almost flower-like petals emanating from the foveal center. This is fluid building up in the outer plexiform layer. OCT, of course, is one of the more common diagnostic tests we perform in the office, and it's very helpful in evaluating patients with CME. What you'll see here is large cystic spaces as demonstrated by the arrows, and our topographical map will show large areas of elevation, which you can see here highlighted by the blue circle. One can also look at the central foveal thickness, which is the center of the central thickness of the fovea. In this scan, that central foveal thickness is 588 microns. This is nearly double what normal foveal thickness should be, and that's an indicator that there is edema or swelling. There's various treatment options for CME. The most common, we usually try drops, topical steroids, and non-steroidal medications. Tend to work fairly well. In cases where topical drops are not working, or cases where the CME is very severe, one may try periocular steroids. You can put that as subtenon's injection or intravitreal. Of course, if the reason for the CME is due to some other underlying condition, for example, a vein occlusion, macular degeneration, then those patients may require anti-VEGF therapy, that is, injections of anti-VEGF treatments in the eye. And finally, in cases that don't respond medically, either to drops or periocular injections, then surgery might be indicated. These are relatively uncommon unless the reason for the CME is due to traction from an epiretinal membrane. Next, we'll discuss central serous retinopathy. This is a condition that usually affects middle-aged men more so than women. Symptoms often involve blurring of the central vision. It's more often unilateral than bilateral. Patients will often describe a progressive decline in central vision, and there is a definitive association of this condition with the use of steroids, as well as possibly stress. On exam, OCT findings will usually show a pocket of subretinal fluid. You'll notice, as opposed to cystoid macular edema, where you saw large cysts within the retina. This is actually fluid underneath the retina. One may also see a pigment epithelial detachment. If you see that small little elevation, dome-shaped elevation, just to the right side of that arrow, or actually a little bit more than just to the right side of that arrow, that little dome-shaped elevation is a pigment epithelial detachment. And on exam and on photography, one may also see some pigmentary changes within the macula, which might denote some chronicity. Again, the OCT findings, the top left picture is showing that large amount of subretinal fluid, and there's also a pigment epithelial detachment there. That smaller pigment epithelial detachment, which is the bottom left picture here with that arrow, is showing that fairly prominent PED. On the right side, we see angiography. There's two findings with angiogram usually in the patient with central serous. The top picture is called the expansile dot. What that means is the early frames show a small leak spot, which over the later frames starts to expand into this larger dot. The bottom right picture shows the more pathognomonic sign of central serous, which is this smokestack appearance. You see there's a leak spot right in the center, and then the fluorescein dye starts to sort of balloon up into a sort of smokestack appearance. And that's pathognomonic for central serous retinopathy. When you see that, that's usually what you're dealing with. Autofluorescence can also be very useful. Autofluorescence sort of examines irritated retinal pigment epithelium, which is the tissue that's underneath the retina. And in these pictures, you clearly see this hyper autofluorescent picture, lots of irritated RPE. The bottom picture is usually what you'll see, which is this sort of funneling of fluid, which then irritates the RPE. And so you'll see this sort of irritated RPE appearance, lots of hyperautofluorescence. The color image, a little more subtle, harder to see what's going on, but the autofluorescence really highlights irritated RPE. Treatment, most of the time, central serous will resolve and without any treatment. In fact, more than 90% of the time, that fluid will resolve. It might take some time, even up to 3 months, but it usually goes away. So most of the time you want to observe. Certainly you want to address the underlying condition. If the patient's using steroids, which is quite common, you'd want them to see if we could discontinue the steroid use. If they're stressed out, so maybe they had a large life event, a family member passed away or something like that, you want to reassure them, and hopefully as time goes on, that stressor will become less prominent. So most of the time observation is indicated. However, in situations where the fluid's not resolving, or if the patient has been symptomatic for some time, more than 3 months, where it just seems like the fluid's not going to go away, one can consider treatments. These involve either laser, you can perform focal thermal laser, or photodynamic therapy, usually reduced fluence. And there's been some discussion about treating this with oral medications, rifampin, anti-mineralocorticoid, something like eplerenone, and you could consider other medications, including intraocular anti-VEGF therapy. So there are a few options, but most of the time you want to give it some time, see if it will resolve by itself. Macular pucker or epiretinal membrane is a very common condition. We see this quite frequently. Scar tissue develops over the macula, and it causes wrinkling, traction, which then causes edema. loss of the macular contour, which leads to blurred vision and distortion of vision. So the color picture here shows a very dense epiretinal membrane, which is that white sort of gliotic fibrotic tissue, and the OCT confirms the presence of a fairly dense epiretinal membrane. That's that hyperreflective band on the top of the picture, and then because it induces traction, you see the retina looks quite wrinkled, and there's even some edema there. For mild epiretinal membranes, usually observation is indicated. You can try to treat these with topical drops, steroidal and non-steroidal medications to reduce some of the macular edema. You can even consider periocular steroids. However, for fairly dense epiretinal membranes that are either non-responsive to medical therapy or that are progressing, then vitrectomy is usually indicated. Bottom picture there shows a very dense epiretinal membrane being peeled from the macular surface. They're usually not this dense. Macular hole. This is also a fairly common condition. It comes in 4 stages. This isn't quite as critical. What is important is that you see a discontinuity of the macula. You see the top picture shows a slightly less advanced case. The bottom picture, of course, shows a more advanced case. It's more obvious, but you see there's a clear discontinuity of the macula, and the fovea is affected. Symptoms usually involve blurred central vision. Because the central vision is affected, it usually involves difficulty reading or identifying small, fine print, for example. See, this bottom picture shows it's fairly subtle. It's difficult to really tell, but you see the vitreous, which is those hyperreflective bands that are sort of floating in the middle of the picture, are attached there to the fovea, which is that fine center, and there's traction there, which is inducing a hole. This hole is very small, and the picture shows it a little more prominently, but it is a very subtle. So these things come in definitely in small, more pronounced holes, and then of course very large holes. Treatment: you can observe some small asymptomatic holes. Octoplasmin has been discussed for the treatment of holes. However, there's been some limited success. Usually these patients require surgery. Vein occlusions, this is comes in 2 different forms. There can be a branch vein occlusion or a central vein occlusion. A branch vein occlusion usually is a supratemporal vessel which is occluded, that is, a thrombus or a clot has formed at the crossing of a vein and an artery. A central vein occlusion, usually a thrombus, develops right as the central vein exits the disc at a place called the lamina cribosa. Either way, they're both clots, and the risk factors for developing clots are very similar to those that would say increase your risk of developing clots in the heart, leading to a heart attack, or in the brain, causing a stroke. These include diabetes, hypertension, cholesterol, a hypercoagulable state, and in the eye specifically, glaucoma is another risk factor. Here's a picture of a branch vein occlusion. You see there's a clear obstruction of this vein, this superior vein, and it leads to blood, and the white spots are actually what are called cotton wool spots, which are little infarcts of the nerve fiber layer. The fluorescein angiogram shows the severity of the vein occlusion. You see the black is really it's really a blocking defect from the hemorrhage, but you can clearly see there's little areas where the retina is being non-perfused, especially near the fovea. And the OCT shows large cystic spaces, elevation. This is cystoid macular edema, like we saw when we were talking about CME. And in this case, it's due to a branch vein occlusion. Central vein occlusion has a very similar appearance, however, tends to be much more severe because it's involving the largest vein in the eye. You see much more blood. Some people describe this as the blood and thunder appearance. I always love that phrase. And the fluorescein angiogram shows much more ischemia. There's much less perfusion, and the OCT shows much more diffuse edema, that is edema that's sort of involving larger portions of the retina. Wide field angiogram can be quite useful. We have this Optos technology, and there's other wide field angiograms. It's useful because sometimes just a picture in the center doesn't really give us a clear view as to what's going on in the periphery. So here you see a sort of a central angiogram, and you see all these little leak spots here. So you can tell this is an eye that has lots of ischemia. There's neovascularization. So this is an eye that's got some trouble. But when you look more broadly, you see why this eye is in trouble. You see all this peripheral area, all these areas that look black is because there's been loss of the blood vessel, of the vasculature there. This is called non-perfusion. This was actually quite severe non-perfusion, and this patient certainly requires treatment. What is a treatment? Well, macular edema and ischemia, that is blood flow loss, are the primary cause of vision loss. Ischemia is difficult to fix, okay? We can't reperfuse or bring blood flow back, at least not directly. Severe ischemia denotes a poorer prognosis. You see this picture here where I've highlighted this area where there's very poor blood flow. That actually happens to involve the macula, the very center of vision. And so even if we treat this eye, there's a likelihood we are unable to recuperate a significant amount of vision. Anti-VEGF therapy has become the mainstay of therapy for these conditions. Lucentis, Eylea, Avastin. Steroids can still be used, and in cases where there's localized areas of edema, or where there's significant peripheral non-perfusion, like we saw in that angiogram, then laser can be indicated. This is what we're trying to avoid: complications of these conditions. Persistent edema can be difficult to manage. These are patients that require constant anti-VEGF therapy or alternative treatments because we're unable to get rid of the edema. Neovascularization is the one of the most feared complications of this condition. This is more high risk if there's a lot of ischemia. Neovascularization can cause vitreous hemorrhage, as you see in that bottom picture, tractional detachments, and then the top picture is showing severe neovascularization of the iris, which usually then leads to a neovascular glaucoma, which can be very difficult to manage sometimes. Artery occlusions are a little different. These usually occur at a branch. These can be also branch or central, but they actually occur instead of a clot or a thrombus. These are usually coming from a embolus, from a plaque, from a peripheral source. The most common sites of origination of these plaques is from the carotid artery or from cardiac nature. So the top picture is showing a carotid arteriosclerosis. These plaques form in the carotid artery, and then one of them can shoot off a little embolus. And then here you see a lot of calcifications in a heart valve. That's the bottom picture. And one of these little calcifications can again shoot off a little plaque, which then works its way into the eye. Giant cell arteritis is another etiology for artery occlusion. This is an inflammatory condition. It does need an urgent workup. Okay, if you see a plaque in someone's eye, there's a higher likelihood that they could develop a stroke. In other words, another one of these plaques could shoot off, and instead of working its way into the eye, can work its way into the brain. And so they need to have immediate workup either in the hospital or at the primary care doctor's office. This should include, this isn't the only workup that we recommend, but it should certainly include carotid artery Doppler, a cardiac echo, ESR and CRP, and of course you could consider other imaging studies and other blood work. And the reason is, like I say, they have a high risk of stroke. Here, the bottom left picture is a branch artery occlusion. You see the retina looks ischemic in that area, and the right picture shows a central artery occlusion. This arrow is pointing to the foveal area, which looks much darker than the rest of the retina. This is the so-called cherry red spot. which is pathognomonic for a central artery occlusion. And the fluorescein angiogram for that branch artery occlusion definitely shows, look at that arrow, you see the plaque, you see the limited blood flow in that artery. That's just such a beautiful picture of a branch artery occlusion. And then the right picture shows a central artery occlusion. You see this dye that's having a hard time working its way into the eye. That's because of limited blood flow. OCT is a little different. This is pretty subtle, so this isn't something we'd expect you to really be able to kind of identify, but you see the inner retina, that is the top part of the retina, looks thicker, and it's not edema. You don't see any large cystic spaces like you did with those other pictures that we saw with cystoid macular edema, and this is a very common sort of appearance for someone that's had a central artery occlusion. Treatment is very limited for artery occlusions. There's a limited window for which treatment would even be effective. Some studies have highlighted this 90-minute window. If the patient comes in after that point, permanent damage is already likely, although this is sort of a controversial topic. Treatments could be ocular massage, topical glaucoma medications, AC paracentesis, to breathe into a paper bag. All these are efforts to dislodge the plaque. All right, you're trying to dislodge this plaque, get it to move down the vessel so that you can reperfuse the eye. There's been some reports of trying to YAG laser the plaque. Again, most of these are of limited benefit, and especially for a central artery occlusion, oftentimes these eyes have a low prognosis even with treatment. Complications, which are actually less common than with a vein occlusion, but these are very similar, vitreous hemorrhage, neovascular glaucoma, and so on. Finally, we'll discuss PVD and retinal tears, and then we'll lead to endophthalmitis. So PVD is a degeneration. The vitreous itself degenerates over time, and as it degenerates, it separates from the retina. Symptoms are flashes, floaters, a veil over the vision, which usually subside over the course of time. Here the picture shows a degeneration of the retina. The top picture shows a partial vitreous separation. You see the vitreous has separated superiorly, but it's still attached inferiorly. So this is someone that's going to have symptoms, but it's going to be difficult to really tell whether or not they've had a full vitreous separation. The bottom picture, the arrow is pointing to that what we call a Weiss ring. The vitreous here is attached to the optic nerve, and when it separates from the nerve, you see a ring. That usually tells you that this patient's had a complete vitreous separation. OCT can be sometimes helpful. You see the top picture shows the vitreous still attached to the retina. That's what the arrow is showing, and then the bottom picture shows what happens when the vitreous separates. You see it's no longer attached to the retina. Sometimes these patients can be at risk for developing complications of a PVD. The percentages are, if they have symptoms, 15% of these patients can have a tear. However, if they have a vitreous hemorrhage at the time of vitreous separation, they have a much higher risk of developing a tear. It's almost 70%. High-risk patients are those with high myopia, lattice, if they've had a tear detachment in the fellow eye, if it's associated with trauma, if there's been recent surgery, for example, cataract surgery, and the risk is usually highest within the first 6 weeks. What we're trying to identify and make sure we treat if we see it is retinal tears. So usually they're associated with PVD, although not always. They can occur in the absence of PVD, for example, in those with high myopia or trauma. And there's lots of different types of tears. The top left picture is showing an operculated tear. You see it's a round tear. This one's got some pigment around it, which tells you that it's been there a while. And overlying the tear, you see this tissue. That's actually the retina. That's actually the portion of retina that has separated. And this is actually a low-risk tear. The upper right-hand picture shows shows two atrophic holes. This is usually a highly myopic eye where the retina is stretched, and you get these sort of stretch holes. The bottom left picture shows a more typical horseshoe tear with associated subretinal fluid. This actually is a retinal detachment. And then the bottom right picture shows a giant retinal tear. This is a huge tear involving various clock hours, and this can only be fixed surgically. To treat or not to treat, you may see us sometimes see a hole and tell the patient it doesn't need treatment, and sometimes we see a hole or tear, and we do recommend treatment with laser. And there's some guidelines. These are definitely not set in stone. These are just sort of rules of thumb. Usually you want to treat tears that are symptomatic, that are associated with heme, that are acute, that is brand new, large. Obviously, if they're associated with retinal detachment or if they've had issues in the fellow eye, probably want to treat those patients. You may not need to treat holes or tears that are asymptomatic, that are chronic. You can see there's pigment around them, that they've been there for a long, long time. Operculated or atrophic holes typically don't require treatment. And finally, lattice, usually not treated, even if there's holes present. Treatment options involve laser or cryo. The left picture shows laser. The right picture shows cryo. You see laser is a little bit more sort of precise. Cryo leaves a larger scar, but they both work well to treat tears. And of course, what we're trying to avoid is getting into a situation where the patient's retina detaches. When the retina tears, fluid gets into that tear, into what we call the subretinal space, and then the retina detaches. It's usually preceded by a PVD, although not always. Patient oftentimes describe a curtain or a shade over the vision or over the peripheral vision. The importance of the macular status is really critical. So if the macula is on, they have a better visual prognosis, and this requires more emergent treatment. They should get surgery done as soon as possible. If the macula is off, meaning the detachment already involves the center of vision, these patients unfortunately have a poor visual prognosis, and as it turns out, the urgency of fixing this detachment becomes slightly less. So RD can come in various forms. Rhegmatogenous is what we usually see in the office. This is a PVD leading to tear, leading to detachment. You can see serous detachments where there's no tear, there's just inflammation or some other condition which is inducing fluid to build up underneath the retina, and usually this doesn't require surgery. And finally, tractional detachments. This is usually seen in diabetics where fibrosis develops that leads to traction, and then it leads to detachment. So top picture here is a rhegmatogenous detachment. Middle picture is a serous detachment, and then the bottom picture is a fairly severe traction retinal detachment. Imaging of RDs is useful. OCT here, that top right picture shows where the subretinal fluid is. You see it's into the macula, peripheral macula, but it's not yet into the fovea. So this patient actually probably has very good vision. This is someone that probably requires surgery fairly soon. The photograph there on the bottom left shows what we usually see in a rhegmatogenous detachment. The retina looks undulated, it looks wrinkled, and you can see the fovea and the macula are definitely involved. So there's a macula off detachment, and B-scan ultrasonography can be useful. Here you see the retina is detached completely. It's only attached there at the optic nerve. So this is a fairly significant detachment on the B-scan ultrasound, and that's what I'm talking about there. Repair of detachment, you can laser some small subclinical limited detachments. However, these are fairly rare. Pneumatic retinopexies done in the office, usually done for superior detachments with one break. You can consider broad indications. What you do is you you apply freezing therapy to the tear, and then you put a gas bubble in the eye. The gas bubble then pushes the retina back in place and tamponades the retina, really. And then once the retina is attached, you can add laser if you'd like, or just manage the patient more conservatively if you've already done cryo. Vitrectomy, you go into the eye, you remove the gel, get the retina back in place, you laser it, and then you put gas in the eye. And you can do sclerobuccal, where you put a band around the eye, and you do cryo at the time of surgery, and then you can use gas in these cases as well. And then you can combine some of these procedures. You can do, for example, a vitrectomy and a buccal. Which procedure to perform is very dependent on the type of detachment. Success rates are pretty good with most retinal detachment repairs. At least this is for primary repairs. If they redetach, then the percentages are lower. Risk of redetachment are those that have already had multiple surgeries, if there's a lot of blood, if the detachment's been chronic or sitting there for a while, if there's already scar tissue present at the time of repair, and there's some other indicators of those that have a higher risk of redetaching. All right, the last thing we're going to talk about is endophthalmitis. This is intraocular infection. It's usually bacterial, but there can be fungal. Endophthalmitis. Endogenous means it's coming from an internal source. That is, the patient had a bacteria or fungus in their bloodstream and it worked its way into the eye. Risk factors are those that have had, say, indwelling IVs, catheters, those that are IV drug abusers. Exogenous is what we usually see in the office. That's due to bacteria or fungus being introduced into the eye from an external source. Most often, this is actually after surgery, such as cataract surgery, or after we do an intravitreal injection. Symptoms are blurred, vision, pain, redness, light sensitivity. It's going to usually occur within a few days after the procedure, and so if it's been much longer than that, it's usually not going to be infection, although that's not always the case. And if it's within less than 24 hours, also usually not going to be infection. Exam will show the conjunctiva is going to look red and irritated. There's going to be edema of the cornea. A hypopyon is white blood cells or pus essentially building up in the anterior chamber, and it levels off, and so you see this all these white blood cells or pus in the eye. You'll see a lot of cells and fibrin in the anterior chamber, and the vitreous will be full of cells, so there'll be a very poor view into the back of the eye. Treatment, if you follow this study called the endophthalmitis vitrectomy study, it kind of gave us some guidelines what to do if the endophthalmitis is due to cataract surgery. We will tap and inject antibiotics if the vision is hand motion or worse, or better, if the vision is worse than that, then usually vitrectomy is indicated. And you can consider the use of topical antibiotics and steroids, and even oral antibiotics. You can extrapolate the results to some degree. However, in general, it's really a case-by-case basis. And endogenous endophthalmitis, that is when it comes from a internal source, requires a workup for where that source is coming from, and usually that patient needs referral to an infectious disease doctor and so on. Thank you so much for listening, and hope you enjoyed the presentation.